So my name is Steve McManus. I'm the Chief Executive of the Royal Berkshire Hospitals, and I'll give a little bit more background about that in a bit. Chief Executive, when I've said Chief Executive, some people have looked at me blankly. Hospital Director may well be another way of putting it. Fantastic to be a UK citizen here amongst European friends, so thank you for having me. I'm even more delighted to see so many people in the room with the words hospital and management in the title, which is great. Also, this talk for the next 20-25 minutes will be the least scientific and the least pre-analytical talk that you'll have. But what I'm absolutely passionate about is leadership and patient safety, and that's what I'll certainly be focusing on. So the other thing is to say well done. Often networking plus alcohol equals resuscitation in the next morning. So firstly, well done in terms of being here this morning for this first session. As I think there's some of our Slovenian colleagues here, yeah, excellent. Said to me last night, you may well be the only speaker who has more people at the end of the session than at the start, as people start to drift in. So thank you for that kind of comment. So what we're going to cover over the next 20 minutes or so, I want to focus on the leadership contribution around patient safety, and certainly how I, as a hospital director or as a chief executive, look at that leadership contribution. I'm going to give a little bit of background about the Royal Berkshire Hospitals, because it's important to locate my organisation in the context of all of you. You all work in busy organisations across Europe, and we're all the same. We're all doing the same thing to the same end, which is trying to actually deliver outstanding clinical care and the safest care that we can. So that context about my organisation and how we do that is also important. And also a little bit about patient safety as it's seen in the NHS as well. I'm going to touch very briefly on values, because something that runs right the way through this talk, but certainly my leadership, is how the values that we hold and the behaviours that we exhibit in the clinical practice that we undertake really helps to drive our focus on patient safety. And then I'm going to put forward three kind of interventions that I believe as a leader are certainly the three things that I focus on around developing a positive safety culture. So seeing safety as a strategic intent, something that we actively think about every day in what we do within our organisations. Really looking at learning being at the heart of developing that safety culture. And the fact that you're all here at this conference means that you are leaders that are learning and looking to improve around patient safety. And creating the right conditions for clinical teams to operate within. So that's what we're going to look to cover. But there's a number of questions for you, I think, as you've seen throughout the day yesterday. So my kind of first question, and this is clearly a bit risky for me in terms of the potential answers there. So the question really is about hospital management and the role in patient safety. So either no discernible role at all, it's all down to clinical teams and people on the shop floor. It's a bit transactional. What I do is look after the money. Or do we have a more kind of active and positive role in the way that we can support patient safety? So there's no right or wrong answers, so let's get a view. Okay, well, my job's done here. Thanks very much. It's been great to see everybody. Well, that's amazing, actually, if the starting point is that there's a view that we have a very active role, which is absolutely kind of my contention. So I want to say a little bit about my organisation, just so as you've got that kind of framed, really. So the Royal Berkshire Hospital is something I'm really proud of in terms of being the Chief Executive, the Hospital Director, to lead that organisation. The building that you see there is the old front entrance, and it's still an active part of our organisation, where we still have clinical services operating from there. We opened our doors. In fact, we opened those doors to our first patient on the 27th of May, 1837, and we've been providing continuous health care, 1839, and we've been providing continuous health care ever since. So it's our 180th anniversary this year. We employ around 5,500 staff, and we work across 6 different hospitals, 1 in Reading and 5 other hospitals across Berkshire, delivering a whole range of healthcare services to a population of just under 1 million people. We have staff from 39 different countries, again, contrary to popular belief, we're open for business in terms of recruitment from UK, the European Union, and further beyond as well. So where we are, where we're located, so we're in the Royal County of Berkshire, and that is located about 30 to 40 miles to the west of London. We're a very rural county, but also with urban conurbations, with kind of populations in large centres like Reading, which is where the Royal Berkshire Hospital is based. We're entitled the Royal County of Berkshire because we also are home to one of the Queen's residents at Windsor Castle. A typical day for us at the Royal Berkshire Hospital in terms of what we do, we are a busy district general hospital with a number of specialist services such as cancer services, renal services. We host the Regional Heart Attack Centre, the Hyperacute Stroke Centre, and we provide various specialist services like bariatric services, as well as a range of general hospital services and pathology services as well. The reason, again, kind of focusing on this is that this is our typical day where the touch points of patient safety. So we have over 1,500 outpatient consults a day, 300 to 400 patients coming through our emergency services, over 1,000 imaging tests, over 1,000 laboratory tests. And they are all touch points where patient safety is at the heart of what we do and is where we need to kind of focus on improvement. The other thing I'm extremely proud of to be involved in is I chair a patient safety collaborative, which is a regional collaborative of 15 patient safety centres across the whole of the NHS. These are hosted within the Academic Health Science Network, and there are 15 academic health science networks across the NHS. Each hosts a patient safety collaborative, and they generally serve a population of about 3 million. And there are 4 major national patient safety areas of focus. So we're focusing on the deteriorating patient, including our sepsis pathways. We focus on maternity and neonatal care, on medications management and medication errors, and also the adoption and spread of best practice around patient safety. So again, it's something I'm really proud of to be part of. It's a really important part of my role as a hospital leader in terms of promoting patient safety. And it's something that we can actually bring and spread into our organisation and beyond. So I said I'd touch something on our values. So our values are really, really important in terms of how we operate. So within my organisation, we have our 4 care values around being compassionate, aspirational, resourceful, and looking for excellence. So those values actually determine the day-to-day behaviours that the staff across my organisation undertake. And I expect the 5,500 staff to behave in a way that looks to deliver the best patient safety and the best environment possible to support that. One of the phrases that we use within the organisation is, the standard you walk past is the standard you expect. So actually, the standards that come through our values and our behaviours are absolutely essential to us. So one of my kind of first areas, first of 3 in terms of the interventions that certainly I see as a hospital leader, as a chief executive, is around safety as being a strategic priority. It's a strategic intent. The role of a strategic leader is to set an ambition based on where you see the capabilities and the opportunities of your organisation. It needs to be a rallying cry. It needs to be a standard that you set within your organisation. And an example of where we've looked to do that at the Royal Berkshire Hospitals, but in a wider context within the system that we operate in, is around sepsis. So we've set an ambition that by 2025, our health system will be the top 20 in the world for how we manage patients with sepsis. Looking to save lives, looking to improve lives. And that's a really stretching ambition that we've set, but it's one that the organisation and the wider system has absolutely got behind and bought into. And the reason that's important is because certainly when we've looked at sepsis in Berkshire West, sepsis in the UK has a really high mortality. It's one of the major killers of our people, of our population, and it's fivefold higher in terms of mortality than patients who are having an MI or a stroke. So time is critical within sepsis. And when our services are under pressure, also, say during winter periods, actually the time criticality around our pathways in sepsis can lead to more patients being harmed if we don't get that right. So we've been focusing very much as an organisation and as a local system on how we can actually make improvements in that pathway around sepsis as a strategic ambition around patient safety. The way we've been looking at is around Safe Sepsis 6 at First Contact. So this is a partnership that we've been undertaking between my organisation, working with our GPs locally, and also working with paramedics that work out of the ambulance service to really extend the emergency department care around sepsis into the community location. We're starting to deliver, say, emergency department interventions right at the point of first contact with our primary care and our paramedic colleagues in people's homes before they're transported to the emergency department, really looking at those red flags that start to indicate a patient with a likely underlying cause of sepsis. So some of the specific aims that we've been working together within that ambition has been the formal identification of the amber and red flags of sepsis when we've been using our screening tools. Been looking at paramedics rather than GPs being first point of contact with patients who are showing signs of those red flags on initial assessment, and looking at the immediate input that we can provide, whereas before we were mainly providing 2 of the 6 sepsis first-line treatments, and actually trying to provide all 6 of those in the shortest amount of time. So the existing care pathways that were evident within Berkshire West as a system was that there was a request for a home visit based on an indication around patient's condition. The GP may well have got to the patient in the afternoon because of having a busy GP clinic in the morning. The red flag around sepsis may well have been identified, leading to an ambulance call, paramedics arriving, oxygen and IV fluids being 2 of the indications started, and then transportation to the emergency department, blood cultures, IV antibiotics, and the sepsis 6 initial treatment then being completed, with a total time of around 7 hours. And we know that the mortality issues around that were absolutely leading to harm for our patients, and certainly weren't in line with the ambitions that we had around being a world-leading organisation and system in terms of how we did that care. With the new pathway that we've introduced again across the whole of the system, that total time's been reduced to 1 hour and 15 minutes. And so early intervention by paramedics, early input in terms of IV antibiotics, and the other aspects of the sepsis 6 pathway is really starting to change for us the whole of that pathway and that ambition that we have about being a leading organisation and system in terms of safety for patients with sepsis. And it is a team approach. So picture here is of kind of our colleagues across our paramedics, GPs, hospital kind of staff, admin staff, who are all involved in that piece of work. And again, leading around that kind of ambition around our sepsis pathway. So the second question I just wanted to pose is, does your organisation have a world-leading aspiration for patient safety? Okay, so quite mixed. So really great that actually in the audience there are colleagues who absolutely have that. Equally, people have been saying that there isn't, or at least you're going to think about that. And I would really encourage all of you, the very fact that you are here as leaders at this event, to be able to go back to your organisations and kind of agitate for that ambition. Because that ambition around patient safety and having a focus around that is a really important aspect of developing the right culture within your organisations. So the second area that I want to touch on, the second intervention, is really around how learning is at the heart of a safety culture. Learning is a safety intervention, and creating a culture where learning is normal behaviour is a leadership requirement, and it's certainly something as a hospital chief executive and as a hospital director, very part of my role is to help create that learning organisation. And within our organisation, our mission is to be an inquiring hospital, an inquiring organisation, where each day our people are considering this question: how can we be better than yesterday? And again, setting that kind of environment so we can question openly about improvement as part of the learning environment. Improvement for patient safety is a really important condition around setting that kind of culture. So within my organisation, we have a whole number of ways of creating that culture of learning. We have learning continuously from trying to understand the human factors where things don't go right. So human factors, looking at simulation, retrying, working with teams about where pathways haven't worked, and being constructive about that learning is a part of what we do within our organisation. Also, creating the opportunity to speak up nationally within the NHS. There is the Freedom to Speak Up programme, our Freedom to Speak Up Guardians, where people, if they don't feel immediately within the context of their teams, they can raise concerns. There are other avenues to do that, because being able to speak up within your organisation about things that aren't going right is really important, and a culture where people can be open and honest about issues that they're facing is again a really important part of that safety culture. But also investing in leadership development. So we partner with the Henley Business School, which is a well-known business school around leadership development. So many of our clinical and non-clinical staff are going through that leadership development, where patient safety is actually part of the curriculum. And also working with industry partners, so our colleagues with organisations like BD, with Cerner, with our academic partners in terms of the University of Oxford, University of Reading, is again a really important part of creating that environment for learning that focuses and supports patient safety. So I just wanted to touch on two particular examples that certainly within my organisation we have looked to develop around this area. So we've been focusing also on how we can look at our Above and Beyond programme, which is a programme of systematically learning from positive incidents. So just like we have incident reporting around some of the things that don't always go well, we've now introduced learning from excellence and positive incident reporting. So we can actually look at the learning from those individual incidents, but also looking at the themes that emerge from those incidents as well. This has been something that our clinical teams have actually developed themselves and have spread across the organisation, and it's now part of our whole hospital reporting on patient safety. It's also something that goes into mortality and morbidity reviews within our clinical teams around where there's been positive incidents that they can actually learn from. And there's a lot of evidence around how high-performing teams are able to look at positive feedback and learn from that. And that learning is a really important part of what they do. And low-performing teams are share twice as much negative feedback than average teams. So we know high-performing teams actually share the positive incidences, and we've looked to do that more systematically across our organisation as part of our learning environment. The other area of learning I kind of talked on is about partnerships, partnerships with our local academic partners and with our industry partners. And we've really benefited from those formal partnerships. This is a good example of that, where one of our interventional radiologists, Dr. Mark Little, has been working on a particular program called Genesis, which is a new intervention around the care of patients with osteoarthritis. And this is a first technique in Europe. And again, it's about our being open and able to look at, with partners, develop new techniques and bring those kind of into the organisation and learn from those. So third question is, within your organisation, is there a systematic way of learning through positive reporting, through excellence reporting? And is that kind of part of your culture? Okay, again, so a kind of mixed kind of bag there. So it's, again, great to see that in some organisations, some colleagues in this room, that there already is that systematic kind of approach to learning. But again, hopefully in terms of the discussion here, may well spark some kind of thinking about what you can take back into your own teams around learning from positive incidents. But again, challenging your hospital management, your hospital leadership, about how positive incident reporting should be or could be part of the culture within your organisation in terms of learning as well. So the final kind of intervention, the final area, is really around how hospital leadership needs to create the right conditions for clinical colleagues, clinical teams to operate in terms of being as effective as possible. And for me, this is in kind of three areas around maximising clinical performance and clinical efficiency, really allowing clinical teams to work to the top of their licence. Enhancing diagnostic capability where there are opportunities to do that, and optimising and standardising the ways that workflows actually take place. And again, have two examples just to run through on that. So the first example, certainly from my organisation, is around our laboratory testing and how we've introduced point-of-care testing through our emergency department around the management of flu, certainly at certain points within the year. We moved to a centralised pathology service in partnership with 3 other hospitals 2 years ago, and that's had many positive benefits in terms of some of the pre-analytical issues that we faced previously, some of the efficiency issues, and being able to actually work at scale. But we also found some of the challenges around turnaround time, particularly for our flu testing pathway, were causing real delays and real challenges within our decision-making for our clinicians within our emergency department, our acute medical units, and beyond. So our ability to use effectively our isolation facilities, our side rooms, our ability to really channel the patients into the right locations around critical care or high dependency rather than standard ward care was being inhibited to an extent in terms of the turnaround time and the way that we were looking at some of our pathology pathways. So again, through working in partnership with our pathology services, working with our clinical teams, introduced local flu point-of-care testing into the emergency department, and the ability to really use that information, that diagnostic test, as part of the pathway to triage the best location at an early stage for patients to be channeled into our hospital capacity. And we found certainly over the last winter period, our use of isolation facilities, having the right patients within our critical care locations, being able to manage kind of patients as effectively as possible with the right resources has really been enhanced through this initiative and this introduction at a local level in partnership with our pathology services as well. Second area, just example to focus on, is around decision support and creating and supporting clinicians with the right conditions around that. We have a 5-year programme at the Royal Berkshire Hospitals to become a fully digital hospital. It's not an IT programme, it's a major clinical and operational change programme in the way that we work clinically and the way that we optimise our pathways across the whole of the organisation. And this has really allowed us within clinical teams, within pathways of care, to look at how we can embed within our electronic patient record, our digital hospital systems, the opportunity for decision support. And 3 particular areas that we've embedded electronically into that digital record is around our sepsis pathway, again to focus and support clinical decision making around right sepsis care. It's also been around our medication prescribing, so our electronic prescribing has supported and assisted decision support in the areas of antibiotic management and the use of antibiotics. And finally, within our pathology services, so our decision support in terms of blood sampling and the right tests to take, again, built up by clinical input into that digital record, has been a really important set of conditions that we've been able to create to help workflow and, again, to really support our clinical teams to work at the top of their licence with the right information available to them. So, my contention, and hopefully it fits with that first question that you very kindly answered, was that the role of hospital leadership, chief executive role, the hospital director, and certainly how I see my role is to create the conditions for outstanding patient care that really values safety at the heart of what we do and really values creating a learning culture as part of developing patient safety within an organisation. And that is very much the leadership role that I see day to day. So my final question, and it may be again a bit risky, going back to that first question, is just maybe ask that again in terms of hospital management and role in patient safety. I'm hoping that I've certainly not lost anyone in terms of that question and people thinking that it's got a significant role. But maybe if we just ask that question again. Oh, I think that might have even gone up 1 or 2%. So thank you for that. Finally, great thanks for having me here. It's the least scientific and the least pre-analytical talk, but I think patient safety, the reason why you're here at this conference and your leadership role as well is absolutely vital in terms of creating that kind of positive environment around patient safety. And certainly it's something that I'm extremely passionate about and see that all hospital directors, all chief executives should have at the heart of their job really focusing on that culture for patient safety. So thank you, and over to you.